Good afternoon, Madam Chair, committee members. My name is Dr. Mary Detri, and I am the Director of Professional Practice for the New Jersey Hospital Association, a nonprofit trade association representing New Jersey's hospitals, health systems, and other healthcare providers. Thank you for this opportunity to provide testimony on a subject that has long been a mission-driven priority for NJHA, its board, and its members. We know that the prevalence of comorbid mental health and behavioral disorders in individuals with developmental disabilities can be significant. These disorders and maladaptive behaviors are not exclusively a function of their disability. Contemporary treatments extend beyond the sole use of medication, with behavioral interventions aiding in improving outcomes for individuals once limited because of cognitive abilities and language skills. We know that when individuals are inappropriately hospitalized, an inpatient stay where there is no clinical substantiated need, the average length of stay can be up to 3 times as long for an individual who does not have a developmental disability. Today, I'd like to focus my attention in my testimony on what I can confidently say is happening in any one of our providers right now. Today, you will see well-intended, compassionate emergency department staff tending to the needs of a 26-year-old son with autism who has arrived not because of a medical issue, but because difficult behaviors could not be managed in his residential care setting. His behavioral symptoms are exacerbated by the lights, the sounds, the activity of a busy emergency room. If he is fortunate enough, hospital staff have been able to secure a transfer for him to an appropriate setting, but that transfer could take days. That same young man will be calmed by what could be upward to 10 days of quiet time in a crisis room, waiting for a transfer to an appropriate residential setting equipped with staff capable of addressing his clinical needs. On a hospital inpatient unit, you will see a 19-year-old brother who, with no medical or psychiatric needs, is unable to receive placement in an appropriate residential setting and instead is on day 126 of a social admission stay. His walls are decorated with things from home. Bed assignments have been changed to ensure that there is a mix of patients on the unit that is therapeutic and safe for all the individuals admitted. And I just want to say that I spoke to one of our members prior to this hearing. They identified that they have several, upward to 10 individuals, some of whom have been there for almost a year for a social admission in an inpatient setting with no medical need to be in that setting. You will see a caseworker helping a 22-year-old daughter who has not had coverage for services since she was 17 because the family was unaware that once she turned 18, she had to be re-engaged with the system of care. You'll see a 32-year-old sister who's been brought to the emergency room for the 4th time this week. Only this time, the residential settings management refuses her readmission to home, and staff are left with no alternative but to provide inpatient admission, even though she doesn't meet the criteria to be there at all. You'll see an elderly nephew who's been brought to the emergency room more than 10 times this past year for treatment of multiple comorbid medical and psychiatric conditions, whose caregivers have long since passed away, and who, like his younger counterparts, struggles with accessing services that would help him age in place. You will see families and caregivers struggling to understand why their loved ones are unable to access outpatient services when discharged either from a hospital emergency room or inpatient units. These examples are not the exception, but instead are all too often the unfortunate reality that many individuals and caregivers experience. Today, you will hear from others in the room about long waits in emergency rooms, the need for inpatient care close to home, fragmentation between the health system world, education, and family resources. My testimony today is not to condemn the system of care, but instead to advocate for change to address the ever-growing, ever-changing needs of these individuals, advocating for a system that brings treatment providers to a place where services are provided that meet both the mental health and disability treatment needs of the individual and provides the wraparound support so desperately needed to both patients and their caregivers. NJHA's members are compassionate healthcare professionals who have implemented evidence-based models of care that focus on addressing maladaptive or dangerous behaviors that can be counterproductive to the patient's goals of care. Every day they work to keep patients safe and to link individuals and caregivers to much-needed supports, but these practices are limited in their scope without a well-structured system. More than a decade ago, I participated on that task force. And we were charged with creating a plan for developing services and supports for individuals with co-occurring developmental disabilities and mental health needs. The task force members represented all areas of the dual diagnosis community, including individuals and family members, advocates, professionals, and state officials. I participated as a representative of NJHA and our members. In large part, the recommendations were not implemented. There's a lot of hard work and a lot of passionate work that went into that, and for the most part, it went in a drawer. We hope that the recently announced proposed investments to care for individuals with co-occurring developmental disabilities and mental health conditions is the beginning of a long-awaited change. We appreciate the administration shining a light on this important topic, leveraging federal funding and increasing the capacity of community-based emergency beds. We applaud the development of a Medicaid behavioral health home, the pilot which would increase capacity for providers to service individuals, and the call for additional state funding to support home and community-based services. Finally, sustainability comes with understanding the whole. We welcome the opportunity to be part of a transparent, inclusive discussion around the review of inpatient stabilization services and funding mechanisms. NJHA and its members are positioned and ready to support the administration and the legislature as you move forward this important work. Thank you, and once again, for allowing us to make our comments today, and we're here to answer any questions or to follow up on anything that you find of interest.